Tell us about you.
So currently, I'm a resident in the Washington Health System. So at the Washington Hospital, that's about 30 minutes south of Pittsburgh in Pennsylvania. But kind of my story. So born and raised here in Utah and West Jordan. And the plan was always to come back at some point. But did my undergrad at the University of Utah. Went to medical school at A.T. Still University in Missouri. So the original DO school.
Okay.
Yeah. And then I just kept moving further east, going to Pennsylvania. The in-laws weren't too happy about it, but they're happy to have us come back soon.
Yeah, Pennsylvania.
No, yeah.
Has that been pretty fun?
We've loved it. It's been awesome for our family. We have a great program, great community right there. So it's only been good for all of us.
You told me a little bit because that's Amish country a little bit.
There's definitely Amish country around there.
Sometimes you get to help those folks.
Yeah, well, so the first time I ever really dealt with the Amish community was in Missouri, because that was also a very big Amish community. And then I just keep going to other Amish communities.
That's cool.
It's great.
They're kind of, give us the bullet on them. They kind of have like a anti-technology philosophy type thing.
Yeah, the majority of them do. Anti-technology, just trying to stick to grassroots, loving Jesus, and trying to do their own thing.
I love it. I did a podcast a while back called "The Amish Were Right," and we just talk about kind of the downfalls of technology on our lives, on our kids' lives, and I think that's funny that that's pretty cool.
Yeah. No, there's definitely some things that they do I couldn't do, but I think they definitely have some things right.
Yeah. What was it that intrigued you about family medicine? What moved you in that direction?
Really, when starting medical school, I jumped all around. I was going in thinking anesthesia, then emergency medicine, then neurology. But really it was my grandma, or my wife's mom, where her doctor, how she would talk about him, is the greatest man alive. And he would always spend personal time with her, just an amazing physician, and she loved him. She would make him quilts for all of his little girls and things like that. And so there's just that good relationship, which I like that. I like talking to people. I learned quickly in certain specialties where you see people for 30 minutes to an hour, and then you don't know what happens. They just go on with their life. And I like being able to build that connection with somebody and hopefully be able to make a positive influence on their life as they make an influence on mine.
That's really cool. So just that vintage relationship-driven care was kind of your core value that kind of pushed you in that direction. That's really cool. Well, very good. So you've been with me just a few days, actually. It's really fun. And so thanks for setting up the rotation with me. Really, Zach's intention in rotating with me was to just kind of learn a little bit about this practice model. You've heard about it. You've learned about it.
Yeah.
Tell me what you know about DPC, and tell me what intrigued you about it and why you kind of are looking in that direction.
Okay. So the first time I ever heard anything about DPC was during my second year of medical school.
And DPC is direct primary care.
Direct primary care, yes.
It's a model of caring for people that's like a membership model that's no copays, no deductibles, come in as much as you want. Easy access to your doc, kind of vintage healthcare like what Grandpa was doing.
Yeah, exactly. And so when I learned about it, we had a physician who was from Kansas, and he came in and he gave this whole presentation about how, he had this service where people paid a monthly membership, and his patients had his cell phone. They had his email. They were able to come in as many times as they wanted to. They're not paying co-pays. And he had a really good relationship with all of his patients. And then also another big point about it was, trying to go away from insurance, trying to make it more affordable, not only to the patient, but just a better lifestyle for him. And then in my mind, when I heard him talking about that, I was like, why isn't everybody doing that? Why is that not the normal? And so as training went on, you're so indoctrinated with, healthcare is only through insurance. Any other way you try to practice it, you're either trying to pander to the ultra wealthy, or it's just not going to be sustainable. Yeah. And so that's why I really want to rotate with you, because obviously you make it work, but I've never been with anybody who does a pure direct primary care practice that makes it work.
Yeah. I love what you said. Why is this not the standard of care all across the board? I really do think it is doable. I would love to see this model of care take over. It's growing gangbusters. When I started 6 years ago, it was maybe 400 clinics nationally, and now there's more than 2,000. You're seeing family doctors see this as a very sustainable way forward for themselves, but also for people, both in affordability, but also for companies, but also for the nation. And you're right. You said, a lot of the conception around this direct payer model, this direct primary care model, has been around the concierge space, and concierge might be quite a bit more expensive than what the average direct primary care clinic is. And because their objectives are different than ours. Ours is really to take care of the masses and take care of everybody in a very affordable, sustainable, really meaningful way. Getting back to those core values, resonating with your core values. And the other thing you said that was interesting was during residency, they kind of pull you in that this is the way to practice healthcare.
Exactly.
We have to be insurance driven. And partially that's because they get subsidized from the insurance companies, Medicare specifically, for your salary. Partially, I think they make right around $45,000 a year per family medicine resident to subsidize that process of educating these residents. And so they're, of course, wanting to plug into that whole model, and that's understandable. I could see that as understandable. Nevertheless, I think that it's time to look at innovative models of caring for people. We have so many pieces that are broken in our healthcare system. As you've entered residency, because again, med school, you're just bright-eyed, bushy-tailed. Yes. Everything is altruistically beautiful, and it's all going to be awesome.
Yes.
And I'm going to be like Grandpa, cart and buggy, and able to go out and talk to people and actually have relationships with folks. Tell me what that journey has been like. As you've entered residency, you've kind of seen some of the pain points. What are those pain points that you've seen in the insurance model of caring for people?
Well, as far as the insurance model of care, really what it is if you want to be a profitable physician, you have to see X amount of patients, typically between 20 and 30 patients a day to be profitable. And
do you know why that is? Because it has nothing to do with greed. I want to be clear about this. It doesn't have to do with greed.
No. Well, and it's because insurance makes new rules, new regulations, and so it makes it harder to compensate the physician. So the only way for a physician to really keep the lights on in their practice is you have to see more patients.
Yeah. Let me elaborate briefly. Each payer, Blue Cross, Cigna, Aetna, Select Health, they all have a contracted rate with the doctors and the clinics and the hospitals. And those rates vary from doctor to doctor. So my rate might be different than the doctor next door's rate, which if we talk about that, it's considered collusion and it's illegal. So they've made that illegal for us to talk about that. They also, like you said, they continue to move the cheese, right? They're like, oh, this is what you need to do to collect a transaction, an office visit. You got to do X, Y, and Z. Well, every once in a while, they're like, on Wednesdays, we don't like that. We actually like it this way. But on Thursdays, then that works. So it sounds funny, but I'm tongue-in-cheeking this just a little bit. But the nuance is that it's that silly. They're very difficult to engage with. So we have to hire more people to go to collect the money that we just saw this person and we're not collecting anything for that transaction. So it just becomes so convoluted. And there's so many people in the middle of that relationship between doctor and person that it becomes very inefficient. It's like when you run a business, you have a merchant processing machine, and that merchant processing machine takes up to 2.5, sometimes 3%. Engaging with the insurance model is like a merchant processing machine that takes 40% away. It's just inefficiencies. Tons of only sometimes you get paid, a lot of times you don't. So those are some of the conundrums to that piece of the equation. What other pain points can you speak about that you've noticed as a newer family doc?
Really it's availability. They cram us with so many appointments. The patients have maybe 15 minutes, and that's pushing. That's a long appointment if you're able to spend 15 minutes with me, and there's just not enough doctors, family medicine doctors doing it now. And so people are trying to get in and see their doctor. You have a 3-month wait for something that hopefully in 3 months is already resolved. And so it's a huge pain point for the patient. And then for me, these are my patients that I'm trying to take care of, but I can't see them because I'm already so booked with everything else.
Has it been disenchanting a little bit for your career choice?
Yes and no, because it does get disheartening when you're thinking about, all right, I'm going to be going out soon on my own, and I want my patients to be able to rely on me, but I only have this much time in the day, and there's not 2 of me, there's not 3 of me.
Yeah.
And it definitely makes it more difficult.
Yeah. I think that's really important. And it's really fascinating to hear, it sounds like you're no longer resonating with your core value of grandpa, right? Like that was, you want to be that vintage relationship-driven care person, but you've given on a long visit 15 minutes really.
Yes.
And a lot of that time is documenting in a computer. And so, yeah, I'm with you. I know that gig really well. From a patient standpoint, what pain points are they suffering? Do you notice that people are struggling to get in? I mean, you said availability, but what other pain points are there?
Availability to get in, and when they're actually in to see me, they may have a list of things that they want to talk about. I have time to talk about 2, maybe 3 things, and they may have 5 legitimate concerns. And not only that, they may have their 5 concerns, but there's also a couple things I want to talk about for their health maintenance, for their health care. And so it's really hard to be able to fit in 7 different health conditions all in maybe the 7 minutes that I'm going to be talking to you.
Yeah. You've been in my office for about 3 or 4 days. Have you seen the difference there?
A huge difference. Yeah, huge difference.
We can go down the list. Remember just yesterday, I have 4 more things on my list. No problem. Bring them on.
Yeah.
And you often hear me say, anything else? We talked about this. Is there anything else? I think people come in with a list, and sometimes they just get, it's so fast that they're like, they don't have time to breathe and just relax and think about other things. And in my clinic, I just keep digging. I'm like, keep on coming, because we want them to be healthy.
Probably the biggest difference, one of the biggest differences that I've seen in your clinic is when they come in with family members. And then the family members like, well, also I have a question too, where in the traditional healthcare model, that's not allowed. If you want to come in and talk with me, or if you want to ask a question, you have to go out to the front. Now you have to pay a copay. We have to make this a formal visit. And so it is completely different.
Yeah. Yeah, we did that a few times.
Yeah.
We're like, the mom is there. She's like, oh, by the way, I got this thing. And then she's like, oh, and Johnny's here with me too. Can we talk about his blah, blah, blah? And I'm like, yes, we can. Bring it on.
Yeah.
And you notice like our schedule's not overwhelmed. It's not overly packed. And so we do have bandwidth to be able to accommodate some of that stuff. So no problems. Well, you had some really good questions in our back and forth. And I want you to go ahead and just kind of, some of those we may have already kind of answered in our banter here this morning, but let's go ahead and shoot down some of the list of things that you want to talk about, and just shoot, and I'll answer questions best I can.
So I know that we've kind of talked about the model of direct primary care, but I think my biggest thing of coming into this is it sustainable? Is it sustainable not only for the patient, but for the doctor? Is this something that can work long term, and is it in the future, is it becoming more favorable to practice this way?
Yeah. This is a great question, and sustainability has multiple factors, right? I'm going to break it down. Let's start with the first one, sustainable for people. Our objective as family physicians, primary care specialists in that space, there are internal medicine docs and pediatricians and other primary care specialists doing direct primary care, but our primary core value is exceptional care to people. And to me, that is what makes it sustainable, because I am resonating with my core values. I love my job. My burnout factor is very, very low because I am true to myself of selves. And so from that makes it really sustainable from my standpoint, and from my client standpoint, because they really enjoy that. Like, cost-wise sustainability, I mean, the sustainability and cost is also important. And by the way, that's why our current model is not sustainable, because it's fraught with all kinds of extra expenses, but it's also fraught with a whole bunch of things that I have to do that don't resonate with my core value.
Yes.
So they take me away from caring for people. And that hurts me. And over time, I don't like my job anymore. And I quit and I sell kittens out of the trunk of my car because it's better than what I'm doing as a doctor. So we have to be willing to look at that and say, is it sustainable for me from an emotional standpoint? Am I true to my values?
Yeah.
And I would say the healthcare system is largely very left-brained. It's very corporatized. It's very much about throughput, and it's very much about people are numbers. Let's get the next one down, and let's crunch all these biometrics, and let's do all this data crunching and all this stuff. And they've gone away from what it was always meant to be, which is just caring for people.
Yes, definitely.
And there are a lot of things in the way. And the beauty about direct primary care is that we cut them all out, and we just put it back in line. I work for you. I want to help and serve you in all the ways, and I don't have all these rules to abide by that take me away from that process. So very sustainable. Financially, price point. And price points vary nationally, demographically, but also, cost-wise, just like cost of living varies. And so I feel like most family physicians, most direct primary care clinics, are just Voyage clinics. Most of them try to stay at a price point that's reasonably palatable for most families. The other thing, that we do, and probably other physicians do something similar, is we just offer scholarships to people that can't afford it, right? I don't care. I'm not working for anyone else, and I can say, no problem. We're going to do free care for you for 6 months or for a year or however long it takes to get you on your feet. We've had a downturn in our economy. We've got a lot of families suffering and struggling, and I don't want any of them to go without good care. So I'm happy to. I have quite a few. My office manager barks at me a little bit, but I think that's part of the beauty of it is that we want it to be sustainable for people, and family doctors will do it for free most of the time. That's our whole thing. We're just like, I don't care. I love people. I just want to help them. And so yes, it is sustainable. I feel for the clients. We can keep our price points very affordable. Most our families, this is interesting. Most our families have insurance. Most of those insurance products are $3,000 per person deductible plans, $10,000 to $15,000 per family deductible plans. That gets them zero actual care. They're afraid to go to the doctor. They're afraid of their copays. They're afraid of their costs. They're confused about exactly what's covered and not covered, and they don't go. And so that's not sustainable either. We got a lot of sick people out there that need care. I've got tons of stories in that space. It's like a medical service mission in America with people with insurance. It's silly. It's silly what's happening. And they very deliberately put those pain points in place to push people away from me. And that's frustrating. And it shouldn't happen. And so we just give it all back for this much more. And so is that sustainable? I think it is. Most of my families save more than they spend with me on an annual basis, despite having insurance. And that's amazing. Like, we can do it very affordably, very cost effectively. I'm advocating for my patients on every front. I sent a prescription out today. I found that over here it was $300. Over here it was $30. Let's send it over there. So that's part of my job, right? I'm advocating for them in all these spaces. So again, I think we are truly working for the financial sustainability of it for the end user, who is the client or the patient or the American people. For companies, again, how does a small company afford a health benefit for their employees? It is not sustainable what we're trying to do right now. So these group plans for a small company are costing anywhere from $1,800 to $2,700 a month per family. So my price point is about anywhere from $160 to maybe $270, $280 a month per family. So about a tenth of what insurance costs, and I deliver upwards of 90% of their healthcare needs. Doesn't mean they don't need insurance, by the way. Let's not confuse that. But how do we get that insurance product to be more affordable? Now, for these small companies, they just don't provide anything to their employees, and they can't afford it, or they're providing those plans, and the employees are getting stuck with $300 to $600 per. Oh, it's more than that. It's probably $300 to $400 per paycheck, right? So $600 to $800 per month fees, and the employers are paying more than that. So not sustainable for most small shops, and so enter Voyage Clinics. Now we can offer something that's 10% of what insurance would cost for them and their employees and for their families. And it's a really big upside. We mitigate workers' comp claims. We help all their employees stay really healthy and active and moving, grooving. So it's a wonderful thing for small shops, small employers. Big employers, a whole nother discussion there. But like self-insured plans with a direct primary care physician in the center really makes a lot of sense. Nationally, they're saving tons of money for these bigger corporations as well. So again, very sustainable there too. So for individuals, for large companies, what about national healthcare, right? Like, can we fix that? I don't know. I don't know that direct primary care was meant to fix all those things. And I think it's definitely not a fix-all program for the whole nation. I think it's a good start. And when you talk about primary care, you're talking of upwards of 90% of people's healthcare needs. And so if we can fix that, get people healthier, better relationships, better trust with their physicians, then I think that we can, a lot of the other things will be better, right? Like diabetes will be better because we will have fought that battle way back there instead of waiting until they're very, very sick. So I do think it's a sustainable model for individuals, companies, and the country if we can just continue to invest in it as individuals, as companies, as physicians. It's risky. It's taking a risk for the physicians. They're used to practicing on this other model, and it's hard for them to step off of that model, especially if they've been indoctrinated that this is the way to do it. And then it's hard to grow a practice from scratch. It's like business. Like you have to be different, and you have to practice differently, and don't necessarily have to practice differently, but you just have to think differently. So I don't know. Those are kind of the long-winded answers to your question. Sorry about that.
That kind of goes into my next question. Someone like myself who is just exiting residency, is the model of direct primary care feasible for someone who's starting off with enormous amount of student loan debt? Can you make it work?
There are docs who have made it work. I think it's with a large amount of risk, and I don't know that risk is super necessary. There's lots of programs out there to help you mitigate your loan burdens. I personally went to a rural setting for 6 years, did rural medicine, got paid down a lot of my loans, really enjoyed rural medicine actually. Probably wouldn't have moved. I'm really, really happy out there. I think it's also, I'm talking to a young resident who I helped start his practice up north, and he's like ready to bag it. He's like, I've got too much debt. I need to work. I need loan forgiveness. I need this. And I didn't, it's just the constraints on my family are too steep right now. I can't grow this other thing. And I get it, man. I get it. And so, I think you just got to look at it and decide, like, is it right for me and my family right now? Or is it okay to just, burn hot on the current system? Don't let it like burn you out or fatigue you such that you quit your profession. But know that there's another reasonable option down the road once you pay down some of the debt. I think that's a reasonable way to approach it. I think it might be worth it to interview some of these residents who have just come right out of residency into DPC and see what they have to say about that. I don't know. My process has been just a little different.
Yeah, and I research a lot of these people who come right out of residency, and I'm not saying that they have a extremely different situation than myself, but I have a family. I have other things that I can't just think about me, because I could survive off of basically nothing, but I have other people I'm taking care of, so it does weighs on my thoughts, and could I make it happen?
Yep. Yeah, I think you just got to look at that, your debt to income ratio, and see if it makes sense. Because when I started, there was a free fall for a fair amount of time, and I think I was break even at like 9 to 12 months, and then profitable at like 18 months, and then making a reasonable family medicine income at like 2 years. So if you're ready to make that kind of sacrifice, and that's with me like working really hard to kind of grow my practice and do that thing.
So if you're comparing the two models with traditional insurance or healthcare and then direct primary care, is DPC for a physician more profitable, or is it you run the same? Is it less profitable?
Yeah, profitable is an interesting word. So and there will come a time when that word means something different to you.
Yeah.
Right now, with pressures, I mean, I think I came out with $380,000 of student loan debt out of med school, and yours is probably right in that same ballpark. That's hard, and so it pushes you to money. I need money to make this all work. To me, right now in my career, profitability to me is spending time with my family and playing pickleball and mushroom hunting and making fun pieces of wood. And, that's really, really important. Nevertheless, the point of your question is important, and I'll answer it. And so I think DPC docs don't do it for the money as much. And our income is probably 10 to 15% less than the average family doc out there right now. That's strapped to a really fast pace, demoralizing, fatiguing operation that they hate. But our satisfaction, our work-life balance, our family relationships are probably 80 to 90% better. So I never go home and document for 2 hours after seeing patients, right? So I'm not doing that. My work-life balance is better. I was able to attend my daughter's lacrosse game last night, and then I went mushroom foraging after that, and I played pickleball today with you, and so that was really fun.
True.
So I think the balance is better, and therefore the profitability is better. To me, it's worth a small pay cut, make a little bit less to be able to have such a better balance in life. But that's, I think there are people who need to grind for a while to pay down debt and work as hard and fast as they can, etc. Just don't lose track of your core value, because that can happen. And then you just want to quit. If you just keep resonating with that core value of good care for people, I want to love and serve and care for people, then you will eventually circle back on what you're meant to be and do.
I appreciate that.
We asked your wife to ask a couple questions too. Can I pop through one of hers real quick?
Please do. She always has questions about this.
Do you want me to do it in a female voice? Just kidding. I won't do that. I'm terrible at that. So here's a question from your wife. Is there better family balance even though you're running a business? So this is a good question. We just talked about work-life balance. But she says, well, you're running a business on top of being a doctor. Is that reasonable? And that is reasonable. That's a great thing to ask. The simplicity of this model means that it just doesn't make it very complicated. Now, is it without complications? No, you still have to run a business. And so a lot of doctors, what happens to them in the DPC space is they start this practice. They're the only employee. So they wear all the hats. And then they get really busy. And then they hate their life and they want to quit. And so the answer to hers is sometimes no, because those doctors just can't hire somebody. They're too scarcity minded to just say, oh, it's worth it for me to take a pay cut, even though I'm not really making money, to hire somebody to take 2 of these hats away from me. And inevitably they hire that one person and they give them 8 hats, and that person quits. And then they're like, I should have hired 2 people. So then they hire 2 people. Meanwhile, they're trying to continue to grow and do that thing. So there are some pain points along the growth trajectory of starting a direct primary care practice, and some of those do interfere with work-life balance, but not even close to the amount that you're enduring on the whip horse machine that you have plugged into. And so that's my answer to that question. I think it is very, very doable. You have to be smart. There are many, many doctors nationally. I do consultants for people. I've met with many of the old veterans and had consultants for me. Hey, I've got this pain point. I'm not sure what to do. I'm burning out. I hate this thing. And they're like, well, here's 4 solutions that we did. Then I might ask another doc, here's 2 things that we did in that situation. And then I'm like, okay, let me try some of these. And then it works. And then you just move on to the next thing. And so we're a very collaborative group. We really want to empower docs to just have this sustainable gig in their lives and to help people and to be true to their core value. So,
yeah. And a side note, how many patients are you seeing in a day? And I'm a resident, so I'm not even at capacity, and I still see 16 to 20 patients a day.
a day or an evening? Because you work half days.
Yes, that's true. That's true. Half days.
Because in residency, what happens is we'll round in the hospital for the first half of the day, and then the afternoons we have clinic, and so or we'll do a rotation and whatever in the mornings, and then we'll come back and we'll have clinic. And so you're seeing that many in how many hours would you say? Like in an afternoon?
I could say 5 hours. 16 to 20 patients.
Yeah.
Yeah.
That's a lot. That's
that is
like
a lot.
3 to 4 an hour. So we see probably, we schedule people every 30 to 60 minutes. So we'll see, 3 to 4 in a morning when you're seeing that, a lot more.
Yeah.
We're also available for telehealth. So during those visits, sometimes we have time to just make a call, answer a question for somebody. And I would say you get probably 3 to 10 of those a day too. Just sometimes they're, hey, my kid's got this rash. What do you think? And you're like, oh, that's molluscum. And we send out a thing. And so, yeah, I'd say you have a fair amount of little questions that might be asked telehealth wise. And so, yeah, it's very, very, very reasonable. And again, we're just trying to be like grandpa, vintage healthcare, get to know them, spend more time with them, smile, talk to them, kiss babies, do the thing, do the thing.
Yeah.
All right. You're up next for a question. Then I'll go back to another one of your wife's questions.
All right. Well, another question. Do you ever regret going away from the traditional care model? Because probably, like you said, at some point you took a pay cut, but do you ever regret it?
Yeah, that's good. That's good. I probably, in rural medicine, this is a huge pay cut from doing that. But man, is the quality of life better. But at the same time, I don't think it's all about the money. Yeah. And so I really loved rural medicine, not for the money. I loved it because it was great for me. I just loved delivering babies. I loved working in the ER sometimes, and hospital and nursing home. And I was, doing hospice, and I had a busy clinic. I was sideline doc at the football games. I was basically a family medicine resident. I was working 80 hours a week and kind of loving it. And I don't know that it was terribly sustainable long term. So I needed to make some changes back there. But I think I would have probably stayed the course. The things that hurt me out there were different. I think the administrative burden was reasonably, it's still dumb, but as far as administrators for my clinic or the hospital, beating you up and telling you to see more patients per hour, I could kind of give them a stiff arm and they'd have to deal with it. And because I was I had enough clout to just be like, no, I'm going to see patients less frequently and you're going to deal with that and it's going to be fine. Yeah. I think, it was, I don't know. I loved it. The reason we moved is because my wife wanted to go to law school and then it forced me into change mode. Yeah. And then I thought, well, the whole thing needs to change. The other pain point that back there that I saw, and it's still going on, is just the meddling of insurance companies in our relationships with our clients. And one of the things that they did was pay for performance. So it sounds like a good thing for the people. But what's happening really is they're paying, they say, well, if you're a good enough physician, if your patients are doing this benchmarks, then we'll pay you this much. But if they are not meeting those benchmarks, then we reimburse you less. So it puts us in a really hard position with our patients, especially when you have a patient that you love and care about that just can't get their health in order. And that happens. That happens a lot. We have a really difficult hand dealt to us in the American culture, multiple things that are hijacking our healthcare, most of which are around sugars in our foods. And people are addicted because they're deliberately addicted because that's the way they want them. And so it's unfortunate. And when someone can't come off of those substances and get their A1C in check and it's hurting, they're now docking my pay for that. To me, that's unethical. So then what happens is those doctors are like, some of them are like, well, gosh, I guess I can't care for this person anymore. So I have to discharge them as a patient. And they have to go find another doctor.
They end up in my clinic.
And they end up in your clinic.
Yes.
No, for real. Yeah. And it's unfortunate. And that shouldn't happen. I shouldn't have some big overseeing monster looking at me and making sure I do a good job. I mean, I signed a Hippocratic oath. I'm here for my people. I'm trying to be the best doctor I can. And if I have somebody barking up my tree, it's just really, really tough, and it's unfair for multiple reasons. And I think their intentions are okay, but again, they need to stay in their ship and let me continue to just manage my ship, and it's okay. So yeah, that's my. I think I didn't really answer your question. Do I regret it or not? I don't regret it, but I don't know that it wouldn't have. I don't know. I would have been okay in a rural setting. I would have been just fine there still. It would have been a lot harder, I think.
Yeah.
I think the fatigue was high. Everything was kind of hard. So no, I don't have any regrets. I love my job. I love my gig. I can be a family doc now for 20 more years and be really happy.
Yeah.
Whereas before, there was maybe a few years left in the tank. It was really hot. I was burning too hot.
Yeah.
Let's go to one of your wife's questions, shall we?
Yes, please.
How much work is being brought home? And that's a great question. So, none. Almost none. Almost none. So the documenting. So that's a big part. Like you have to do all this documentation stuff for insurance purposes, mostly, not for documenting purposes.
Yes.
Insurance wants things put a certain way into a note in order to bill, code, and collect and make that work. And so it's really brutal. And again, has nothing to do with family medicine, has nothing to do with caring for people, just has to do with interfacing with the inefficient machine.
Yes.
And I have fixed all that. So I don't do any of that stuff, and it's wonderful. And I do document my notes, but I just don't have to bring it home and document for an hour when I get home.
Yeah.
When I was in residency, I was doing that. When I was in fee-for-service, I was doing some of that. And it was hard. It was hard on the family. Now I'll get a call every once in a while. I'll get a text. I'm a telehealth guy for my people, and I'll answer. I'm like, hey, excuse me, I got to step away for a second. Got to answer a question for somebody. But I was doing that before too. Right?
Yeah.
So I don't know that that's much different. Every once in a while on a Sunday, I'll have to go throw stitches somewhere, but frankly, I enjoy it. I get out of Sunday school that way. Bummer. I guess I got to go do stitches. But no, I do enjoy that, and I don't mind being that kind of vintage doc that's available after hours for my people. My wife talks about, and your wife gets this too. She gets to have a family doctor in the family. Yeah. And how nice that is after hours or whenever, when something goes sideways, you can just consult for your kid and say, hey, this is what's going on with little Johnny, blah, blah, blah. And Voyage clinics or a direct primary care clinic is very similar to that. And Shauna is very kind in that she lets me do that for a lot of families. And that's great. They love it. I love it. Everybody loves it.
That's awesome.
Yeah. Any other closing comments or questions at the end here?
You've answered so many of my questions. I can't think of anything on the top of my head. I just really appreciate coming here and being able to work with you, see how you do everything and just how it runs.
Yeah. You have some things put in place as far as your plans. Do you mind just kind of sharing that with us, and then how you might look at direct primary care in the future if that is in
Yes. So I have signed a contract with a practice a little further north in West Jordan, and I think it's going to be great. And again, it comes down to I have a lot of student loans, and so that was always the plan, but it's always the talk between my wife and myself. What if we tried something else once we paid off some of these student loans? What if we did something that is better not only for us, but also for the people I'm taking care of? And so there's always that thought, do I do this?
Very good. As that journey matures, as you move along your path, I'm here for you. Just reach out. If I can help you start your own practice, or if you want to do something with me, that's great. I think it'll be really fun to see your career go forward and how you move forward. I think that's a great path that you've chosen, and it's totally fine. And so it's not the only way to be a family doctor. There are many, many ways and many right ways, and it's okay to do other things for a time. And you get to feel the burn and feel what that feels like. And if it's reasonable, then stay the course. Yeah. If it's not, then maybe make a change. And you're not beholden to this system. You can step off of it if you want to in the future, with lots of people like me willing to help you. Yeah. I just spoke with a doc who is a little bit north of where you'll be. He's probably another 45 minutes north.
Mm-hmm.
He and I spoke at length several times, and he just had a lot of questions. He's thinking about starting his own DPC practice, and he's weighing the pros and cons, and he really likes his people, all of his clients, and he's having a hard time switching over.
Mm-hmm.
And eventually he came to the conclusion for himself that it was best if he stayed the course. And I'm like, that's great.
Yeah.
There's nothing wrong with that. Like people practice their whole lives on that model, and it's okay. And it's getting a little bit worse as time goes on. But if it's still reasonable, and if you can within that system work in a way that's true to your core value, then stay the course, man. It's totally fine. My biggest thing is stay true to your why. And your why is like my why, taking really good care of people. And so just stay true to that. Your journey will guide you along the path of whatever, and just resonate with that and just stay on that frequency, and you'll be fine.
I appreciate it.
Cool, man. Well, thank you so much.
Thank you.
It's been really fun.
Yeah, it has.
Hope this brings some good insight and education to other family docs thinking about moving in the direction, and even other people that are looking at direct primary care as a sustainable way to receive care.
Yeah.
So thanks again for the interview.
Well, thank you.
This is where we have an awkward pause.
Mm-hmm.
And I have exactly 20 minutes to talk about fungi.
Okay.
Okay. Do you want to sit in with me, or do you want to just chill?
I might just chill because I don't know a whole lot about fungi.
Yes, you do. Stay with me. It'll be
all
fine.
right.
It'll be fine. Let's get rid of these papers. Just put them down. Yeah, anywhere down. All right. Hey, y'all. Dr. John with the Voyage Clinics podcast. And today we're going to be talking about fungi. Fungi in nature, but also fungi on your body. So sometimes we get that. And so we'll go into that. Today, I have a family medicine resident with me. His name is Zach Hansen. He's cool. And he's just going to be here and just answer questions. We're just totally winging this thing. Very little planning has gone into this. But in April, this magazine, one of my favorite magazines as a little guy because it has lots of pictures, National Geographic, has some of my favorite fungus on it. These are morels, morchella. These are black morels. Oh, yeah, probably, yeah. Or half freeze. I can't tell exactly. But these are morels. They're one of the most sought after mushrooms out there. They're super delicious, and they hit us during springtime. It's spring right now. I've already foraged a whole bunch of these and shared them with my office staff and done all that. Yes. And yes, they do grow in Utah. People think they don't. You just have to bird dog, man. You got to bird dog them. They're hard to find. They're all over. The Midwest has way more than we have. Like Utah is very scarce, but we do have some along our creeks and streams and stuff. Mushroom foraging, fungi farming, whatever you want to call it. It's been a hobby of mine for a few years. I really enjoy it. And have you ever looked into it, Zach?
No, I haven't.
Okay.
Nope. The first time I saw you and went to your office, I saw a big old pot of mushrooms. I was wondering what was going on.
Yeah. They're not psilocybin. They're not psychedelics. These are just edible, yummy mushrooms. The first thing I'll tell people who are interested in going to foraging is you got to be really careful. You got to know what you're dealing with. Often just go out with somebody who's done it a bunch. Get a book. There are many books. David Aurora has a whole couple of really good books. One is All the Rain Promises and More, which has a creepy guy with a trombone on the front. He looks creepy. He's kind of, I don't know what that is, but it's funny. But it's a little field guide. It's small, fits in your pocket. You can take it with you. That's a good starting place for mushroom foraging. He has another book, that Mushrooms Demystified. I like his stuff because he comments on their edibility. It's really good. A lot of mushroom people, mycologists, they call them, they're not into commenting on that because they don't want to be held liable if somebody gets sick, right? Yes. And so identifying mushrooms is the trickiest part, and you have to know what you're doing, and it takes time. So I wouldn't venture out and just start picking mushrooms and eating them. I wouldn't do that. I think you could kill yourself. There are several that will put you in the ground in Utah, and then the rest will give you lots of diarrhea and vomiting. And then there are some that you can eat and they're yummy. So that's the gist on looking for them. In a previous podcast, I spoke with Dr. Nyberg. He's a psychiatrist friend of mine. We talked about the benefits of foraging and just being in nature, smelling nature, seeing the creeks or streams, The Japanese have this Shinrin-yoku where they go out in the wilderness and they just forest bathe is what it's called. It's literally translated as forest bathing. And so you immerse yourself in the forest. They have green zones, which are just forest, blue zones, which have some water flowing through them. And you're just there and you're present and it's healing and it's wonderful. Yeah. And I went to a CME a while back, this last year, and they talked about nature medicine.
It seems like that's kind of becoming a larger thing nowadays. I've been hearing all about it.
The Amish were right.
Oh, yeah.
Just go out in nature and just eat pie. It's fine. Right. It's fine. But nature medicine, immersing yourself in nature, breathing, smelling, being present, grounding into the earth, taking your shoes off, like I'm sometimes crawling on the dirt when I'm looking for mushrooms. It's so stupid. But it's very satisfying and fulfilling for me, and it's calming for me, and there's some recharge that happens mentally and emotionally for me. So for what it's worth, forage mushrooms, really fun. Springtime has certain mushrooms. Summer has certain mushrooms. Fall has certain mushrooms. And in your area, it will vary. So find some people that are willing to share their favorite fishing holes with you, because most mushroom foragers are like, I don't know what you're talking about. There's not a Morel in Utah, not one to be found. Don't know what you're saying. So they won't just share stuff. So you got to actually go out there and hunt and find stuff. And it's fun. It's a sense of adventure and foraging, kind of fun. Let's talk about fungi on the body. So common places where fungus hits. I want to talk about flora. So fungal flora. What do you know about fungal flora, Zach?
Well, yeah, flora all over your body. And it's just the natural biome of your body all over. Now it's when you get an overgrowth of specific fungi on a specific part of your body. We tend to think like, athlete's foot, jock itch, some of those really dark, moist areas on the body, which a fungus can thrive, just like in the wilderness and more dark, moist areas.
Gosh, you said moist twice. That's my wife's favorite word.
I'm sure it is.
It's her least favorite word. But you're right. Normal flora, Canada. Is Canada evil?
No.
Is it normal flora on your skin?
I believe that
it can totally be normal flora. Yeah. If it overgrows, can it cause a problem on the corners of your mouth?
Yeah.
What's it called? Angular cheilitis. And I say it with a southern accent because I trained in the South. Angular cheilitis. And so it's the kind of cracking corner of your mouth that's kind of fussy. It's either fungus or a B vitamin deficiency. That's my understanding. And so, but it can be just normally on your skin too. And there's a lot of people who are like, oh, Candida overgrowth, it's because you have a leaky gut and you blah, 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 and you're eating too much sugar. Any stressful state can cause an up-regulation of noxious bacteria, et cetera. Or fungus. And so if you're stressed, if you're doing extra things, you can get the angular stuff. My daughter had it in college. She was extra stressed and not sleeping well. And so Candida, a normal thing on her skin, just create a little infection. Yeast infections, very common. pH balance down there is really important. Avoiding like overly cleaning and things like that down there are super important. It usually sorts itself out. Where else can we get yeast? Nasal yeast infections, oropharyngeal yeast infections, commonly from like inhalers, asthmatics, people that are inhaling steroids or squirting steroids in their nose. There's a lot. Spring allergy season, so I'm using Flonase, but you want to rinse your mouth out so it doesn't hit your mouth. These are corticosteroids that kind of like inhibit your immune system just a teeny bit, but they also drop down inflammation a whole bunch. So my symptoms of allergies, I'm not sniffing and sneezing right now, but there's a little risk with that medicine with mostly the inhaled steroids. I haven't seen it with the Flonase as much, but so oropharyngeal candidiasis. Where else can yeast affect us? I've seen it in creases on necks. I've seen it under
breasts,
in armpits, under breasts, under like abdominal folds and things like that in these kind of dark, wet places, moist as you said.
Yes.
So that's Candida. You can get systemic Candida infections. You can get them. It can end up in your blood. It can end up in your gut. It can end up in a lot of places, and it can overgrow and cause problems.
Yes.
Treatable?
Definitely.
Yeah. So if it's topically, like if it's topical, we have topicals for
There's
that.
topicals.
We've got like lots of Canada medicines for those. Oh, thrush. Kiddos get thrush. Little babies get thrush really commonly. I got thrush in college. I'm from a small town, clean air, clean water, clean living. Went to Vegas for undergrad. Got super stressed, just major culture shock, really, really hard. Got really, really sick. And that sickness just persisted. And then my immune system came down and I just got thrushed like a baby. Babies get thrush because their immune system is naive. They're still kind of learning and growing. And then, thrush happened. And so that's very, very common.
Well, and I think you see it a lot in the healthcare system when you're prescribing antibiotics, you're killing good bacteria, bad bacteria. And it's a great way for yeast to start growing. And so I have a lot of people you treat for a UTI and then they think a week later that it came back even stronger. It's like, no, you now just have a yeast infection.
That's a great point. That's a great point. We have to be very judicious with antibiotics, and we're better about that as a whole. I think the younger docs are getting better trained and stuff. So that's really smart. That's a good comment. Thanks for that. Sometimes with the babies with thrush in their mouths, they'll spread it where to mama.
Well, that's true.
Because they're breastfeeding, and then mamas get it on their nipples, and it's super painful.
Yes.
Also treatable, topical stuff, very easy, but cracked, painful nipples, and kids got thrush. Look for Canada there as well. Gentian blue, have you heard of this?
Gentian blue, no.
Anyways, or it's gentian violet. It's gentian violet. Anyway, it's a topical anti-yeast, antifungal thing that they used to use way, way back before I was a baby. But they still use it sometimes. It turns out, it turns your nipples purple.
No, I must miss this one.
Yeah. Well, look it up. It's kind of cool.
Will.
Yeah. Okay, so I think that covers most of the yeast stuff. Let's go on to some of the other fungi. So you mentioned like jock itch and so let's talk about those guys. These are like the Tinea corporis, and so these are a different kind of fungus, but very much present, and we can get it in our scalp. So we get this seborrheic dermatitis, this like scalp, it's like the dandruffy thing, but it's fungal, right? And so we treat that with like ketoconazole shampoos. You can get it on your face, the flaky little thing that happens here and in eyebrows, also called seborrheic dermatitis, also treated with topical antifungals, really hard to get rid of completely.
Yes.
Yeah. The tinea, what other tineas do we have? Tinea corporis, which is like the wrestler ringworm, right? Yep. It's the ring, it's got a raised border, scaly, and you can get it anywhere on your body, really. Those are pretty aggressive, also very treatable, just topical antifungals, super easy. Yep. You can get the ones in your head that are like those big
tinea
ones.
capitis.
Tinea capitis is bad.
Yeah.
Do you know what the big old? Have you seen one of these? Ooh, I saw one of these.
I saw one on a kid, and I thought I was gonna have to start like taking biopsies and doing stuff like that. Like, no, it's just I can't remember what exactly it's called, but just treat it with an antifungal and it'll go away. Yeah. Didn't look like it was gonna go away, but
there's a fungal infection of the scalp that looks like Jell-O, and it's nasty, and it's just like goopy, goobery grossness. I had a guy, he was a homeless kid, actually younger, in his 20s in Moab, and he came in with one of these, and they call it, the name escapes me, but
I'm not sure.
But it is just a really bad fungal infection, like a carry-on. It looks terrible, and it was fungal, and we treated him with orals, and it went away. But man, that was a process. What other tineas do we have? We've got tinea capitis, tinea cruris,
tinea pedis.
Tinea pedis. So you've got like the stuff on your feet. So athlete's feet. Tinea manus.
Yes.
This one people miss this one. I've had like 3 people in the last year who I treated for tinea manus who just went years and years thinking they had dry hands. One was a dentist. He's like, I had this for 20 years. It's only my left hand. And he's got this scaly looking classic tinea manus hand. And I'm like, whoa, let's just treat that. So I gave him some orals, went away, and he like came in and gave me a big old hug. He's like, thanks, doc. I didn't know I had a fungal infection. The tinea pedis, sometimes it presents classically like in the cracks of the toes and you kind of get the little scaly stuff. But then sometimes it's like just a general, almost like tinea manus, where you get this kind of flaky, kind of white color, crusty looking stuff. And that's, people think they have dry feet. Yeah. But they actually have tinea pedis. And then often with that comes the onychomycosis fungus.
Yes.
So, and those two are very much related.
Yes, they are.
And so then you get the thickened toenails that kind of create, and those are really tough to treat.
Yeah.
Really tough. Spray out your shoes, spray out your sandals, fast-acting tenactin, bleach stuff on occasion. Bleach kills all fungus. And that'll help mitigate some of that foot fungus thing. Tinea versicolor, I trained in Florida. Do you see any of this?
The only time I've ever dealt with it is on board exams. I know what it is. We talk about it a lot, but I've never personally. No, I lied. There's one patient, and it's because he was spending a vacation, I believe, in Taiwan.
Yep.
So warm tropical area, and came back, and he said, "This isn't the first time I had it. Last time I had it was when I was serving in Vietnam."
Yeah.
Like, okay.
Yep. If you start looking for it, you will find more.
Yeah.
Just like look on, like it's usually like down into the chest area. It can be on the backs. People call it sunspots.
Yeah.
And people will get a tan and they'll notice it before, like in the winter months, they won't even know they have it. And then in the summer months, they're like, why is my tan all splotchy? It's tinea versicolor.
Yeah.
In Florida, warm climate, very humid. We saw all the time. I got this because I was playing sports. I was playing, between classes, I played some ping pong. I get all sweaty. I'd sit for a while, and I'm just sitting in this sweaty shirt, right? And so it's perfect environment, the perfect moist environment.
That's some intense ping pong you're playing.
It is. Oh yeah, I play with some Chinese guys. They're intense. And so, so tinea versicolor, very common sunspots, very difficult to treat because it's often so widely dispersed.
Yes.
If it's just a little couple patches, I'll treat that topically, but often I'll treat that orally as well, just because it's just a tough one. They often reoccur. So whether it's tinea pedis, tinea curris, tinea versicolor, they often reoccur. Washing your sheets and your clothes and all that stuff does mitigate that a little bit, but don't be stressed out if you get another patch of it here or patch of it there.
Do you ever recommend like Selsun Blue? Because that is one of the first line treatments. And for the person that I dealt with, he said it works great.
Yeah. Selsun Blue is awesome. Selenium sulfide, Head and Shoulders. I think there's also a Pert Plus dandruff. They all have selenium sulfide in them. Selenium sulfide is the active ingredient that helps out with mitigating fungus in general. Okay. So both the seborrheic dermatitis here, the seborrheic dermatitis here, anything on your skin as well. And so it's a good idea to just once or twice a week. I don't like the smell of Selsun Blue, but some of the other ones smell a little bit less intense. But yeah, no, they absolutely work. Especially for prevention of it ongoing, but I don't like it for like trying to get rid of it because I've had people like, I've got really bad dandruff. I'm gonna try Selsun Blue. Tried it for years and still not helping. So you got to just go with the big guns there. Okay. And the big guns are still reasonable. They don't hurt people. Yeah. I don't even like to say that, but I accidentally did. Okay, cool. What other fungi do we need to talk about today? Oof. I think we hit on all on Canada. We hit on all the tinnias. Those are good.
Onychomycosis, obviously, you talked about because a lot of people come in talking about their toenails getting thick, yellow, or discolored, and what can they do about it. Yeah. And I work a lot with the podiatrists, and I don't know. You have a lot of differing opinions. You have, majority of the podiatrists, they don't touch it. They don't like to deal with it because we don't have a lot of great treatments for it. The topicals don't work very great. And some of the orals, they don't want them on it long term. And so it's really tough to treat that.
It is tough. I'll give you a couple pearls. So if they start getting it either in their hands or feet, most commonly in feet, but if they get it in there and they just start getting some yellowing around the edge, the very edgy edge, and some thickening just barely into it, it's not affecting the base of the nail yet. Okay. Then you can just do like cyclopirox lacquer, like there's the prescription lacquer. Yeah. And that works okay for that level of it. But if it's invaded into the nail bed, then you gotta treat it orally, debulk it, laser it, sand it down, have the podiatrist go in there and Dremel it all off and stuff, and then debulk and debride. And it is brutal. It's a really tough thing to treat. But yeah, those are the pearls there. Gut fungal infections, is this a thing?
Not that I've dealt with a whole lot. Gut fungal infections.
Here's the thing. You'll have these like some of these folks will talk about like leaky gut and all this stuff. And does that exist? Yeah, it does, but I don't like the term leaky gut. It's a dumb name.
Yeah.
And it makes you sound like a pseudoscientist. Like, the gut doesn't leak, dog. You'd be dead. But what happens is just like we have good flora on our skin, we have good flora in our guts. And the American diet sucks for supporting and sustaining good good gut flora. How do you maintain that? Leafy green vegetables, we just need lots and lots of veggies, and the gut flora will be really happy and do really good by you. If you don't, then you can have that phenomenon that really compromises your immune system. I think it predisposes us to a lot of the autoimmune situation that happens here. And there's a whole bunch of bad processes that happen from just not supporting the gut. I'm a big fan of kimchi. I make my own kimchi. I love fermenting stuff. I do that all the time. In a lot of cultures, it's a huge part of their culture, and in ours, we just don't do it anymore. I don't know. We need more kraut and kimchis.
I was gonna say, I don't know. In Pittsburgh, they have the pickle festival, so they love their pickles over there.
Are they fermented or are they just pickled though? Because fermented pickles are delicious.
I know it depends on who you go
Probably
to.
some of them are.
I was gonna say it depends on who you go to.
Probably the Amish pickle.
I'm sure.
We love the Amish. That's our theme. We just like the Amish. Cool. Well, hey man, thanks for the discussion today. I think we hit on all the fungal things that I want to hit on. Jock itch we didn't talk too much about, but it's again topical treated. It's like an itchy jock area. You can get it in your butt crack and stuff like that too. Just leave it with that. I think that's a great ending comment.
Yes, I
talk about butt cracks. Anyway, hey, thanks for joining me on our podcast today. Hopefully it was helpful for our audience today, and like and subscribe and do all the things. Thanks.